will not ensure that the public is provided with pharmaceutical services of higher standard and which will improve their health outcomes. This only comes from an accepting the ideals of the profession. Knowledge is a prerequisite for competence and provides the framework for good practice, but knowledge itself is not sufficient to be a competent practitioner who makes positive difference to people's life. That requires commitment. Without commitment, we are just talking nonsense, right? And the take-home messages: to be a good leader, never stop learning. This morning, because of the time difference, I wake up at around 3 o'clock in the morning. There's a time difference of about 4 hours between Malaysia and Oman, right? So I couldn't sleep. At about 3:50, I wake up. The first thing what I did, I like to read all the latest development in the medical field. So I opted to read what are the table of content of this week's JAMA, Journal of American Medical Association. There's a very interesting article, today's JAMA, about treatment of hypertension in diabetic patients. And there's a lot of controversial things going on about treatment of what is the target level that we want to achieve. There was a very interesting editorial in JAMA today. There's also another interesting editorial in Medscape today about the use of technology for screening for syphilis, the use of smartphone technology with the apps and lab-in-chip-based technology for diagnostic purposes. That is quite interesting as well, right? So never stop learning. We all are very busy, but never stop learning. You need to find time for that, right, to read some of the latest development and so on and so forth. Mentoring, I think this is lacking as well, even in my country. We need to change this paradigm as well. Do what you love and love what you want to do, okay? Embrace change. A leader makes things happen. Step out of your comfort zone, right? So always remember, we cannot be practicing in a very closed-circuit environment, right? And healthcare is changing, technology is changing, right? This is very important things that we need to think. Finally, speak up for the patient, speak up for safe medication handling practices, speak up for medication therapy that makes sense. We can do this, we must do this as a leader. So thank you very much for your attention.
Thank you very much, Professor Azmi, for interesting lectures. We continue on this session on the pharmacy leadership. Our next speaker is Professor Arnold Holto. Professor Arnold is a professor of hospital pharmacy, and the CV he has me is very rich. For the sake of time, he is professor of hospital pharmacy, he is a pharmacologist, he is a scientist, he is a researcher, he's a member of so many societies, and he published a lot. So please welcome Professor Arnold.
Thank you. Good morning, ladies and gentlemen. Thank you, Professor Bavazir, for your introduction. And first of all, I would like to thank the organizers for inviting me to this beautiful country. I had the opportunity to travel around a little bit, and those who come from abroad, I would like to encourage you to see how wonderful this country is. I'm also happy to attend this great conference. I had a look around to the posters and looked through the program, and there are indeed some very contemporary issues to be discussed these 2 days, which I think will be worthwhile. And last of all, I would like to thank you for having the opportunity to share some of my personal experiences in hospital pharmacy from the past 30 years. A special word of thanks to Sarah Al-Balushi, who has been managing me since the FIP meeting 2013, and again from Bangkok in 2014. And well, there wasn't a week without an email or an app, WhatsApp from her, to keep me on track. Yesterday, we heard from Professor Christine Jolowski about the achievements of American Society of Health System Pharmacists since 1942. I'm a proud member of ASSP, and you can question yourself, how could ASSP take this leadership role in the world? It's not only because they had excellent leaders, and the previous speaker showed a few of them, like Bill Selmer and Henry Manasseh, of course, but because what I have seen is that they paired innovation in practice development with research. They showed the benefits of hospital pharmacist interventions and actions. And that improved very much the acceptance of the role of the hospital pharmacist, the clinical pharmacist. And that is why I think research plays a key role in developing leadership in pharmacy. And in my talk, I will elaborate a little bit on the personal experience I had with that. But first, let me introduce a little bit of my background. This is mainly the map of Europe, but at the far down right side, you almost see Oman, not really yet. But if you go to the center of the map, then you see the United Kingdom, and opposite of the North Sea, there's the Netherlands. This is a map of the Netherlands. We have, as you have in Oman, also different regions, and I'm in a region, what is it, the brown color is called Zuid-Holland. And here is my, this is my work location, that is Rotterdam. A few words about pharmacy in the Netherlands. The Netherlands has some 17 million inhabitants. It's a much smaller country than Oman. So it's a densely populated country, and you have only 4 million people living here. We have a little bit more than 5,000 pharmacists. We have about 100 hospitals, and you see them here on the map. So it's densely populated not only with people, but also hospitals are always close by. Those hospitals are serviced by 65 hospital pharmacy departments, and almost 600 pharmacists are working in the hospital. 450 of them are specialist hospital pharmacists. What does that mean? It means that they have, on top of a 6-year undergraduate curriculum to get a master degree and a PharmD in pharmacy, also a 4-year training, residency training in hospital pharmacy. So for the Netherlands, it has been used since 2000 that people get a training of at least 10 years to become a hospital pharmacist. We have about 105 residents in training doing this kind of training, and that is financed by the government. This is my institute from the top of the roof, and this is what is being constructed at this moment. And if you're coming to have a coffee with me, you will find me in my office just there. If you can find me. Okay. A small interval, because just recently I became aware of that Erasmus MC Rotterdam is going to train Oman medical specialists. And we are really proud between the collaboration of our Minister of Education and your Ministry of Health. And that's why I choose to spend 2 minutes of your precious time to introduce my institute to you.
Who are we? And what is our mission? It's a universal question. We reside in a special place, in a beautiful world. This place can be pretty amazing, and we call this place our home. I would like to ask you to hold still for a minute and to think about what it is, what we do. Because sometimes what is normal is actually quite special. We dare to step forward in research, education, and healthcare with great optimism, exploring new grounds. This is how we create our future, step by step, day by day. Every now and then, something will happen. In these moments, we will be there. Rest assured, we are ambitious. We learn by doing. And this is how we are known. We also like to share our knowledge, because we believe in keeping an open mind and in making informed choices. Exciting? Yes. Extraordinary? Absolutely. We are ahead of the curve to give you all the attention you need. This applies to you, and him, and her. Welcome to our world. We are applied thinkers. Our purpose lies with excellent healthcare, because staying healthy is a happiness we all deserve.
I think this shows ambition, this shows courage, and that's what we need if we want to show leadership. So why is then research in hospital pharmacy important? Well, one of the supporters that we really need is the management of the hospital. And hospital pharmacy is getting more and more important because of the huge amount of money that's involved, and we will come back to that later. Drug budgets are exploding at the moment. And another issue that is very important for the hospital management is safety. Hospitals are definitely an unsafe environment unless we do a very hard job. And many studies have shown that feeding practice with research eventually improves the quality of care, and we have heard a lot about that yesterday. And I have the experience that if you collaborate with doctors, medical doctors in research, that the appreciation for the pharmacy is also very much increased, not only by participating in patient care. Where did I come from? I did a training, undergraduate training in Groningen University, and I get a research training in Utrecht University in neurochemistry. And then I was a chief pharmacist for 7 years in the only academic veterinary hospital. And out of that came a number of master's theses and 6 PhD theses. And the way I did it was liked very much by the Erasmus University Rotterdam, and that's why they hired me in 1995. So what did I have there? Well, actually, not a pharmacy that was at that time academic. There was no research budget and there was no staff for that. But there was an ambition to start doing research, and they just told me, well, have your way. And I must say that with all the plans I developed over the years, almost never I got a no. Not when I asked for money, but if I had great ideas and I wanted to change things, they usually gave my way. We had a teaching duty. And that was very important, and it also was important to get our role established in the whole organization. Because as a rather unique situation, the hospital pharmacy is responsible in the medical faculty for all the pharmacology and therapy training. We are coordinating that. And that is a unique role that gives you a lot of power in such an academic organization. At that time we had 8 pharmacists, among them 4 hospital pharmacists. I was the only PhD, and we had 4 residents. And we had 1 MD clinical pharmacologist in our team. The total staff at that time was 70. But, very valuable, we had a therapeutic drug monitoring laboratory with 4 technicians, because therapeutic drug monitoring usually is within the realm of hospital pharmacy in the Netherlands. And what have we achieved now in 2015, 20 years later? The pharmacy became academic in 2004. We have now 2 full professors, 1 associate professor and 1 assistant professor. We have 30 pharmacists, which is relatively small as compared to UK and US standards, but we have a different form of practice, which we believe is very efficient. Among them, we have 14 hospital pharmacists, 9 PhDs, most of them from our own breed. We have 4 clinical pharmacologists. We have 6 residents and 11 general pharmacists, and some of them are working on a PhD. So it's a complete change in almost everything. We have 1 MD internal medicine, that's our professor of clinical pharmacology, and our total staff has doubled. We have now about 10 laboratory technicians. The average annual of peer-reviewed publications from our pharmacy is now about 40. So a lot has happened. And how did we do it? What were the assets that we have in 1995? As I said, we had this laboratory with advanced equipment and good and well-trained technicians. So we could support pharmacokinetic studies. So we had skills that were useful for doctors. In the pharmacy, we had a clinical trial unit where we are supporting all doctors that are running clinical trials. We had a clinical pharmacologist on board, and we had our hospital pharmacy residents. Because of this 4-year training program that we offer, there are 6 months differentiation, call it specialization, and 6 months research, which is extremely valuable if you know what you want to do and how you want to spend that time. So most of the residents that work on such a research project get 1 or 2 papers out of it. And on top of that, we had pharmacy students, undergraduate students that were doing 6 months research also in our pharmacy. And of course, the network that we had in the hospital via teaching. Our teaching had priority. No show in teaching is just a death sentence. If you don't show up, you're gone. So that was very important. But the fortunate situation was that they were just completely overhauling the clinical phase in the curriculum, where the emphasis is on our training doctors in their therapeutic skills and prescription writing. That resulted in extensive negotiation with the leading staff of most clinical departments, because we had to buy time from them in the clinical clerkships from the medical students. And they were very happy to do so, because they believed in the purpose of what we want to do. And that is how we made friends. Always try to make friends. Don't fight them. It doesn't help you. And regarding research, we looked for a research niche in the Dutch hospital pharmacies arena. Many people were working on pharmacokinetics and all kinds of things, so there was no use for us to do that. Oncology, that was already covered by 2 other academic centers. So we found our allies in the strong clinical departments in our hospital. And I will show you now just a few examples of how we made allies in our institute, and in this, let's say, 20 years, we were able to achieve this big change. First of all, we had to focus our research. We had to find our allies in our institution. And that's actually what you can do yourself too. You know which departments are really good and which departments are mediocre. So support, well, you can actually lift with the good ones to the top. And we had a very strong department in transplantation medicine, so we are the largest transplantation center of the country, and there was not another academic center yet focusing on helping the transplantation programs with, for instance, therapeutic drug monitoring of immunosuppressants. And by the way, that was also the interest of the professor of clinical pharmacology, which I can show you later. In addition, we also have the largest pediatric hospital with a lot of research going on. So we started a research program in pediatric and developmental pharmacology. We also saw a niche in supporting drug development in biotechnology. Pompe's disease, which is a very rare lysosomal storage disease, was more or less discovered in the Netherlands, as was the therapy with myozyme. And I was able to participate in the team developing this very expensive drug treatment, and the first trials were done in Rotterdam, and we are still on the top in the world on in that area. We now are treating about 100 patients. We have the largest cohort in any institution in the world. We started with enzyme therapy, and at the moment I'm moving now to gene therapy to treat those patients. But we were also opportunistic. When there was an opportunity to support somebody and we thought, well, this may be useful for us, let's make friends, and then we connected with those allies. And of course, you needed to have some luck. For instance, in that era, tacrolimus was introduced and needed TDM support. The transplantation lab couldn't do it because they were just a 9-to-5 lab, and our lab had a 24 hours a day, 7 days a week service. So it was easy to make friends. The doctors came to us because they liked the service that we were providing. At the same period, mycophenolate was introduced as an immunosuppressant, and I was invited to write a review on that, and I teamed up with Dr. Teun van Gelder. It was a transplantation an internist with transplantation experience. And later he joined our department, and now he is the professor of clinical pharmacology. So it all helps to make friends. There was another opportunity then. The new trial started with a central nervous system drug that needed TDM support, and we were able to provide around-the-clock service. So again, we got more friends. A very special thing that we at that time had in the Netherlands was that we were able to combine our hospital pharmacy residency with a training program to become a PhD. That was a 6-year program, and the basic residency was 4 years, was paid for by the government, so you only needed 2 years of money to support that. And with the help of medical departments, we were able to do that. So we were able to develop a very effective prophylactic therapy of treatment to avoid fungal infections in transplantation patients. Another opportunistic choice was that we were supporting the Department of Liver Disease, where they were trying out a Japanese treatment for hepatitis C that was based on glycyrrhizin. That also resulted in the end in a full PhD project. Several research projects from our residents, like a simple question: tramadol is a pain relief drug that is used in the Netherlands, and we thought, isn't that a good drug to give as a suppository, because many patients post-operatively start to vomit, so you should not give them a drug orally. Well, we never ended up doing the trial. We started this with the Department of Anesthesiology, but during the initial, when we did a short feasibility study, we found out that these patients, even with a rectal administration of tramadol, got sick. So we never did a trial, and we abandoned the use of tramadol at all for this indication. We also, as I said before, we embarked on advanced academic research. From the clinical trial unit, we heavily supported the development of myozyme, and now we are running almost any new drug that is coming in for the treatment of Pompe's disease. We run this also in our patient cohorts. And as I said, we are developing now this in gene therapy. And then there are all kinds of questions that you may have, and you can actually do simple studies to figure that out. For instance, what do we know about off-label use? It started as a student project from 2 pharmacy students, Lionne van Rossum and Kirsten Schimmel. They both now have their PhD. And we were looking at how elaborate was the off-label use in our hospital, why was that so, and couldn't we change that, and what kind of research effort was needed to change that situation. Out of the collaboration with pediatrics, we started a study where we looked into the possibility to change the TDM practice. These newborn kids are treated with caffeine, maybe also in your country, and you have to be, you need TDM to monitor closely what's happening with these patients. Usually you need a vena picture to get blood from these patients, which is not very nice. You have these extremely small babies, and you try to avoid that. So we developed a technique that we could sample saliva from these babies, and we could do TDM in the saliva. And that was the combination of a student project, a hospital pharmacy resident, and a medical resident, Saskia de Wild, who will be one of the professors of clinical pharmacology later also in our institute.